Hello, my name is Peder Myhre from University of Oslo and Akershus University Hospital in Norway.
Hello, I'm Biykem Bozkurt, Editor-in-Chief of JACC Heart Failure.
Hi, my name is Scott Solomon. I'm Professor of Medicine at Harvard Medical School and Brigham and Women's Hospital.
We are joining you today to go over a late-breaking trial, the DELIVER trial analysis that's going to be published in JACC Heart Failure, looking at the influence of NT-proBNP on efficacy of dapagliflozin in patients with heart failure with mildly reduced EF and preserved EF. So I'm going to first turn over to Scott and talk about DELIVER, which is very exciting. And tell us about the DELIVER trial, Scott.
Well, Biykem, DELIVER was the largest and most inclusive trial of patients with heart failure with mildly reduced or preserved ejection fraction. We enrolled 6,263 patients, randomized them to dapagliflozin or placebo. It even included patients who had heart failure with improved ejection fraction, who had previously had an EF that was below 40%, patients who had been excluded from other trials. We included patients who were either ambulatory or hospitalized. And we found after a median follow-up time of 2.3 years, there was an 18% reduction in the primary composite endpoint of cardiovascular death or worsening heart failure, which consisted of either a heart failure hospitalization or an urgent heart failure visit. And importantly, we saw that effect across the entire spectrum of ejection fraction with no hint of attenuation as ejection fraction went up. We also saw benefits in every single one of our pre-specified subgroups, and we've been lucky enough to publish in your journal one of those subgroup analyses that Peter will tell you about.
Thank you, Scott. This is so exciting because it truly solidifies the role of SGLT2 inhibition in patients with heart failure with mildly reduced and preserved EF. Peter, tell us about the NT-proBNP subgroup analysis.
Yes, thank you. It's actually a very interesting topic with NT-proBNP in patients with heart failure and mildly reduced or preserved ejection fraction. Because previous trial, there's been a signal that they derive more benefit among those with lower NT-proBNP at baseline. That was in iPreserve and that was in TopCat. And even in heart failure with reduced ejection fraction, in the Victoria trial, we saw the same signal. And then we wanted to see, is this also something that is evident for SGLT2 inhibition in patients with heart failure and mildly reduced and preserved ejection fraction?
So this pretty much demonstrates that there is benefit with SGLT2 inhibition across all spectrum of ejection fraction and NT-proBNP. You can find this paper in JACC Heart Failure at jacc.org. Thank you so much for attending.